Aster Center of Excellence for Orthopaedics and Rheumatology is one center which covers the entire gamut of orthopedics. Whether you talk about arthroplasty, hip and knee joint, whether you look at your ankle joint, if you come to your upper limb, the shoulder, the hand, if you look at the spine, pediatric orthopedics, ortho-oncology, and something really special, a total center for sports medicine, which is one of its kind in the state of Kerala. All that is available in our Center of Excellence for Orthopaedics and Rheumatology.
So we had a 23-year-old girl recently who came in with very severe elbow stiffness and pain. Now, she was a known case of rheumatoid arthritis. She was referred by the rheumatologist. She was quite functionally impaired because of this pain and stiffness. In fact, she couldn't do much with her left arm at all. So we had a discussion with the rheumatologist, and we decided that the best way to manage this patient would be to basically have a discussion with her as to what her expectations are. We made sure that medically she's well controlled with the rheumatology medicines. And then we went ahead with an arthroscopic surgery for her elbow. Now, the advantage of arthroscopy is that you have smaller scars, these keyhole surgeries. The recovery is much quicker and there's much less pain for the patient. So we went ahead with the arthroscopic surgery, and we managed to get a good release of the elbow. And on further follow-up, we managed to have very good range of movements for this lady, and she's extremely thrilled with surgery. Now, this is one of the examples where a multidisciplinary teamwork worked quite well to bring about a successful outcome for a patient. And I think this is what we aim to do at Aster.
Joint replacement surgery is one of the most successful surgeries in modern day orthopedics. In the last 20 years, it has evolved a lot. A lot of development in technology and a lot of improvement in understanding of human anatomy and biomechanics and those things. A few years ago, I was doing a study on patients who underwent joint replacement surgery, probably initial period of the surgery in Kerala. That's around late 90s and early 2000. So I came across this gentleman who was a retired police constable who underwent surgery on the left side in 2000. But he disappeared for follow-ups after that. So I got his address and I contacted him, and he came to me and we had a chat on that. He said he underwent the surgery on a conference done by international faculty. But he was not very happy with that result of that. Even though he wanted surgery for the other limb, he didn't turn up for the other limb. And it was nearly some 6-7 years after the surgery that I met him first. So I talked to him, I told him that a lot of things have changed from 2000 to now. Like a lot of technological advancement has come. A lot of improvement has come in the design of the processes and the surgical technologies and those things. So things were much better then, because in 2000 we used to talk about 10-year survival for the processes, and now we are talking about 30-year survival for the processes. Unfortunately, that the surgery which was done was a little loose on that side. So he wanted surgery on both sides. So I did a revision surgery on the left side. Then he was quite happy with the results. He was willing for the surgery on the other side also. So we did surgery on both sides. He was completely back to his normal activities, like he went for Shabarimala Darshan, Tirupati, Tirunelli in temple and all that. So he was completely back into his routine activities, and he was into farming. And he had a skin disease which got infected, and he went to a local hospital for treatment. And they started local treatment with antibiotics and all, but unfortunately it spread up. And he came back to me after 1 month. The knee also got infected. Actually, what he needed was a re-revision surgery, and at that time, Aster Medicity started, and he came over here. And Aster Medicity has a real focus on joint replacement surgery with all the facilities. We have a dedicated theatre for that, computer navigation, and total femur replacement. All facilities are over here. So I told him that it's very easy to do over here. So he underwent a re-revision surgery over here, and we had a very good physio setup. He was back to his normal activities like a primary surgery, and he's again into his routine activities. He's 82 now, but he doesn't look 82. He's as active as a 70-year-old man.
I remember the 6-year-old girl who was a brilliant student in school, good in dance and good in sports. But unfortunately, one day her mother noticed some difficulty in doing some dance movements. On further closer examination, she found that she was having a swelling in her right upper arm. As all parents, concerned mother and father rushed to the hospital with the child. I examined her and I found that she had a swelling in her right upper arm, which, as per the age and site, were all pointing towards a malignant or a tumor that can spread to other parts of the body or is dangerous to the life of the patient. So we want to confirm that. So what we did is we did an X-ray and MRI, which pointed to a fast-growing lesion. But still, we needed to know the exact diagnosis. For that, what we do now is called a needle biopsy. Though very simple procedure, unless you get the right diagnosis, your further treatment plan cannot be fixed. So once the tissue is taken, sent to the pathologist who gives us a diagnosis, and then we have a team meeting where we actually discuss the case and then decide on the treatment. So I have an excellent pathologist, a radiation oncologist, medical oncologist who gives the chemotherapy or the injections required for the patient, then the plastic surgeon, the whole team helping me out in doing these complex procedures. So her case was discussed. This was a case of osteosarcoma, a tumor that is seen basically in this age group of patients. So the basic protocol is giving chemotherapy or injections first, which was started, and after 8 to 9 cycles of chemotherapy, we take her up for the surgery. The surgery was the most difficult part because she's only 6 years old and she's only this tall. The routine conventional procedures cannot be done because we can't put a routine implant in her. The only question the child asked me in the OPD was that, "Uncle, will I be able to draw and dance?" That changed the whole story. Previously, when you have a malignant tumor in the upper limb, what you do is you actually remove the whole limb. You take it off, and for a child that is traumatic and more traumatic for the parents. But currently now we have more techniques by which surgery has improved over a period of time, by which the limb actually can be preserved. Here we don't take out the limb, but we only take out the bone that is affected by the tumor so that the patient still has his or her own limb back. And as you know, orthopedic oncology is never a one-man show. You need a whole team. So I have myself a big team of pathologists who gives me the diagnosis from the tissue I give. I've got a medical oncology colleagues who give the chemotherapy or the injections that are required to treat these tumors. Then I have the surgical oncologist, plastic surgeon, a whole team to help me out with all these things. So we had an MDT meeting where we discussed all new cases and the treatment plan was fixed and we started on chemotherapy. And good for her, she started responding to chemotherapy. The pain came down, the swelling subsided, and luckily the lung lesions also decreased on chemotherapy. And once she has completed 8 to 9 cycles of initial chemotherapy, we took her for surgery. That was a big challenge. You can't put in a normal implant, so we'll have to do something out of the box to help her out. For this, I think we have something now called extracorporeal radiotherapy. Though technical, what we do actually is that take the tumor bone out, send it to the radiotherapy department. They give high dose of radiotherapy, 50 grays. 50 grays is equivalent to kill all living cells. So it kills all the cells, including the tumor cells. So basically the tumor bone becomes sterilized. It contains no more tumor cells. And that bone is brought back to the theater and fixed back to the patient. So that the patient has his or her own bone back after the surgical procedure. This is a technically demanding procedure where we need to have a team to help you. Radiation department, which gives you the high dose radiotherapy, and the orthopedic team to help in all the fixation. And luckily we were able to manage this. So after the surgical procedure, the child still had her own limb and she was able to start drawing at the end of 2 weeks. And after surgery, we still gave her further chemotherapy, and once that was completed, we took her for surgery for the lung lesion. And those lung lesions also got operated. Currently, she has now completed a year after chemotherapy. But as you know, cancer can come back at any time, so we need to keep her under very close follow-up. So keep reviewing her every once in 3 months, take an X-ray and see how things are progressing. And touch wood, if all goes well, we might still get a cure.
Sports medicine is a new multidisciplinary subject which has been recently introduced in India. Right now, there are only 6 MD qualified sports physicians in India. In Kerala, Aster Medcity has started a dedicated sports medicine wing. As sports medicine, what we target is not only the physical aspect, but also the psychological, the nutritional, the biomechanical aspect as well. I had a 16-year-old tennis player who had come with complaints of breathing difficulty while playing tennis. We did a complete comprehensive assessment, a head-to-toe examination, and we did something called an exercise-induced spirometry. So we did the spirometry before and after exercise and came to the conclusion that he had an obstructive pattern and was diagnosed to have something called exercise-induced bronchoconstriction, which is a variant of asthma. So we started him on medications, but he was quite apprehensive because on medications there is a chance for doping. So what we did is we taught him something called refractory training, which we exercised just before the matches, and we tried it out, and it was quite successful on him. Also, we did something called, I said earlier that not only physical aspect, we do also psychological aspect. So we examined him and we found out that he lacked motivation in certain aspects. He had peer pressure, parental pressure, and we corrected those while sitting with a sports psychologist. When doing the assessment, we found out that his performance level was coming down slowly. So what we did is we did something called a biomechanical analysis. We compared his old videos and we started checking his service shots, how his pivoting movements are, and we found out that it lacked in certain areas, and we corrected those, and he started improving quite significantly. And right now he's come to almost national, and now he's entering into the international circuit.
We had a 30-year-old housewife who presented from North India to a gynecologist. Primary reason has been she has been married for the last 10 years and she's been having recurrent abortions. So presented to the gynecologist, who felt that there could be an underlying rheumatological disease, as she also had some joint pain, rashes in the legs and all that. So she was referred to me for further evaluation to see, one, is there an underlying rheumatological cause, and the second thing was, what is this rashes coming back. So when we evaluated this lady, we found that the patient is having systemic lupus erythematosus, or a simple term what we call as lupus, along with one more condition called antiphospholipid antibody syndrome. She has gone to multiple doctors, multiple hospitals. It has never been diagnosed completely. So we could make a definite diagnosis. So I spoke to the gynecologist who was treating her and told her this is lupus with what we call as APS, and we need to start on treatment. So we started the treatment, and she also started certain blood thinning agents so that pregnancy can be sustained. And anyway, at the end of 3 months, she became pregnant. And during the pregnancy, we had a flare-up of disease. This is what happens in lupus and all these conditions. They tend to flare up. So during the pregnancy, we had to increase the dose of immunosuppression, and we had a little tough time in controlling the disease. But by the end of 8.5 months, we had a team. We had to get the pediatric cardiologist get involved, because sometimes what happened is that the heart of the baby can get involved with these conditions like lupus. The management of this patient was basically with multiple departments, where the nephrologist was involved, the pediatric cardiologist was involved, of course the gynecologist, the dermatologist. So as a team, we could make sure the patient delivered successfully. So even though the patient delivered, I would put it as we delivered, because end of the day, the story was complete because of the team, which helped to make sure the delivery went safe and happy.
A 60-year-old lady presented to my OPD with severe low backache. She was not able to take few steps. She was seen in other hospitals in UK and US while she was on a foreign trip, and they had taken an X-ray and told that she was quite okay. But considering her pain, I repeated the X-ray, and in that X-ray I was able to pick up a lesion in the sacrum, pelvic bone. And on further imaging, it turned out to be a secondaries from another primary cancer. So we went ahead and did a biopsy and stabilized the pathological fracture, and the biopsy came as primary was from the lung, and the patient was pain-free from the next day. She was able to walk, do her daily activities, and further treatment of chemo and radiation for the lung cancer was done in this hospital. Although the survival of this patient is around 1 year, she could live her last years without pain, which shows that early diagnosis of spinal diseases will help us to improve the quality of life of the patient.
A lady in her late 40s, she was a school teacher. She came with complaints of a huge swelling in her hand. That's a recurrent swelling. It is a swelling that happened in spite of having 2 or 3 surgeries done previously in a government hospital. So her main worry was that in the hospital which she had consulted, the doctor had offered her amputation, because it is a tumor that kept on coming in spite of so many surgeries now. But again, he had assured her that it's not a cancerous swelling, but again, to get a proper clearance of the tumor, you need to remove the hand. That's what they told her. And she was very much worried about it. So she wanted to know whether there was a possibility of salvaging the hand, at the same time removing the tumor completely. So she came to the oncology OPD, to Dr. Subin. Dr. Subin was quite sure about the removal of the tumor, but again, he was not sure about the salvage part. Subin had consulted me, so we had a very detailed discussion regarding how to manage this case. And finally, we came up with a plan. We had explained to her that we cannot guarantee you full functional recovery, but at least we could bring you to a position where you'll be able to do your regular work. That's what we had promised her. She was very cooperative in the sense anything less than an amputation was acceptable to her. So finally, she had agreed to the surgery. And it was a 12-hour operation, that's what I remember. And finally, it came out successfully. Dr. Subin had removed the tumor along with the lower end of her forearm bone, and he had used a bone graft that was harvested from her leg. And my job was to cover the entire defect with flesh, which we had taken from her thigh. So we transplanted some flesh from her thigh to the hand with microvascular surgical techniques. And about a year later, she came to me. She was extremely happy, and that time what she told me was for the past so many months, she was doing her profession without any problems. And functionally, she's able to, write on the blackboard, which she never thought that she'll do. So these kind of surgery bring a lot of gratification to us doctors, because in spite of all the effort that you take, it really makes a difference in one person's life.
Anxious mother of a child with tibial hemimelia came and asked us once whether her child will walk or not. Tibial hemimelia is a rare condition where one of the bones in the legs will be missing. So we reassured her that her child will not only walk but even run. Relief on her face was palpable at that time. We then outlined the series of surgeries that a child has to undergo over the growing years.
This is the X-ray of the child that Dr. Imtiaz spoke about. Normally there are two bones in the leg. One is the tibia, the larger bone, and the fibula, the smaller bone. Here you can see that the lower half of the tibia is missing. A child with this rare congenital anomaly cannot walk unless reconstructive surgery is done. The first of these operations entails getting the tibia and fibula to fuse, in other words, to create a synostosis. This operation has gone well. The second operation we hope to do close to 1 year of age, which involves stabilizing the ankle, and this would enable the child to walk at the age of 1 year, which is the normal age when children walk. Subsequently, we hope to lengthen the leg because there is shortening of this side, and the child may need a series of lengthening procedures as the child grows. I would emphasize that pediatric orthopedics entails dealing with small children, and they need to be followed up till they're completely grown, that is, till they're skeletally mature. So the outcome of our treatment would only be known a lot later than now.